staffing to a minimum. I thought I would do today's rounds on post-PE syndrome, which remains largely controversial. There we go. So for objectives, defining what is post-PE syndrome, or what do we think it is, the relevance of residual vascular pulmonary obstruction in the development of PPES, pathophysiology and natural history, primarily for post-PE dyspnea and CTED specifically, and briefly for CTEPH, and then a brief review of screening and management for either. So defining post-PE syndrome, it is essentially an umbrella term for three distinct entities, including post-PE dyspnea, which is a form of PPES that lacks evidence of persistent thrombotic obstruction, but persistent functional impairment after an acute PE event following sufficient anticoagulation. Within that umbrella, there's also chronic pulmonary thrombotic disease, or CTED, which is a subset of PPES with no pulmonary hypertension at rest, but there is evidence of persistent thrombotic obstruction on imaging. And then CTEPH, which we all know is the subset associated with pulmonary hypertension at rest. While these entities do overlap, there's uncertainty as to why some people develop symptoms in this setting of residual vascular obstruction while others don't, and vice versa. When looking at the incidence of post-PE syndrome, this study from 2023 was pretty large. It was a retrospective study of over 21,000 patients. Looking at symptoms developed after an acute PE event for those that received a minimum of 3 to 6 months of anticoagulation and had no previously known pulmonary hypertension or evidence of chronic thrombotic disease at diagnosis. Overall, they found 56% of patients developed at least one new symptom that was not present prior to their acute PE diagnosis, with the most frequent symptom being dyspnea at 21.5%, followed by general malaise at 18.5%. This study from 2020 was a prospective study of 845 patients, which they followed over time. The majority of patients were unprovoked at their index event, and 52% of them did have evidence of RV dysfunction at diagnosis. So an intermediate risk patient population primarily. They were followed for 6 months to investigate the development of new or worsening symptoms after a minimum 3 months of anticoagulation, minimum of 3 to 6 months of anticoagulation. And overall, they found that there was incidence of 65% in terms of persistent symptoms, largely associated with functional impairment that was compatible with post-PE impairment. And 35% of them did recover to their pre-PE baseline. Primary or major symptoms included, again, exertional dyspnea at 32.8%, an overall reduction of exercise tolerance nearing 50%, with a splattering of other symptoms, including exertional angina and exertional palpitations. In comparison to those who had reduced exercise tolerance, those who fully recovered were typically younger. They were primarily unprovoked and less frequently had RV dysfunction. They did additional investigations on this population, including echo and further imaging studies. And what they found was that of the 65% that remained symptomatic, repeat echo demonstrated a range of characteristics, with the most or the majority having LV dysfunction at further follow-up, followed by 27% having intermediate probability of pulmonary hypertension. Conversely, the majority of asymptomatic patients had no echo abnormalities seen on further investigations. Looking further into the etiology of these underlying symptoms for these patients, the majority were found to have left-sided diastolic dysfunction, and that was the reason for their persistent dyspnea, while other etiologies included reduced EF, valvular disease, atrial fibrillation, COPD, coronary artery disease, as well as obesity, malignancy, psychiatric disorders, and autoimmune processes. While CTEPH was only responsible for 8.4%, which is a pretty high number, but the population primarily was a higher risk category. And they found an incidence of CTED at 3.3%, which is also an interesting statistic given the anticipated incidence of CTED, generally speaking. In conclusion, they concluded that exercise intolerance, although it was common, it was mostly more common in those that had presenting RV dysfunction at the acute diagnosis, and persistent cardiac dysfunction was the most common finding on subsequent investigations for etiology. This was one of the studies that sort of raised the question of there being some persistent cardiac dysfunction after the acute event secondary to myocardial injury in the setting of acute RV overload in the acute at the acute diagnosis, leading to sort of subclinical RV dysfunction and functional impairment long term. Going back to the prior study, or the more recent study that was done, that was retrospective of 21,000 patients, they discovered that despite these persistent symptoms that were present in over 50% of the population after having an acute PE event, the utilization of further investigations and imaging studies to just delineate the cause of those symptoms was very much lacking. The question of the role of residual vascular pulmonary obstruction in the development of PPES and the umbrella term for all of the heterogeneous etiologies for that, they found that, well, this was a prospective study of 647 patients with an incidence of residual obstruction around 50%. Despite this, sorry, I think that's next slide. Sorry. Those that had residual vascular obstruction tended to be older age. They tended to have a higher clinical severity at their index event, as demonstrated by their PESI score, and were more likely to have an unprovoked initial event, while the absence of residual obstruction was associated with a less anatomically extensive index event. In this population, the CTEPH, or official CTEPH incidence, was around 2.5% at 2 years and 3.4 at 3 years in those that had vascular obstruction. Additionally, a recent meta-analysis from last year investigated the association between residual vascular obstruction and symptoms suggestive of PPES. And while 48% of those that did have residual obstruction reported persistent symptoms, 34% of those that did not have any residual obstruction also reported symptoms. So overall, they concluded that while the presence of residual thrombus did increase the risk of developing symptoms with an odds ratio of 2.15, there was insufficient evidence to suggest definitive causation. Looking at the entity of post-PE syndrome, of post-PE dyspnea within the syndrome specifically, this is defined as a new or worsening dyspnea, chronic exercise limitation, impaired quality of life, occurring 3 months after effective post-PE anticoagulation in the absence of significant persistent vascular obstruction. And it remains a diagnosis of exclusion. In light of the growing evidence suggestive of persistent cardiac dysfunction after PE, that is independent of elevated pulmonary pressures, one of the suggestions of the pathophysiology behind this is a two-hit explanation, being patients that have underlying risk factors and are well compensated, therefore not overly symptomatic from chronic disease, develop a PE which induces transient myocardial damage that leads to down the road cardiorespiratory impairment and sort of an unmasking of their previously present chronic disease. Alternatively, general deconditioning has also been demonstrated to play a major role in the development of post-PE dyspnea. This was a 2017 prospective study. It was quite small, including 100 patients with a first episode PE. And their baseline population was generally quite healthy. 13% had a prior diagnosis of asthma or COPD, 1% had active cancer, and 1% with known coronary artery disease. And the mean CTA obstructive index was 28%, and their mean BMI was 29.4, 29.5 was their mean BMI. Overall, 45, nearly 50% of patients did show exercise limitation, as noted by a reduction in their peak VO2 max, which is a marker of aerobic capacity on cardiopulmonary exercise testing. Those that had a reduced VO2 max also reported significantly lower health-related quality of life, dyspnea, and decreased walking capacity, as shown by the 6-minute walk test, in comparison to those that had an expected VO2 max after PE. When looking at the correlation between decreased functional capacity and residual obstruction, they found that while there was a reduction in overall clot burden over time from diagnosis to 12 months post-diagnosis, on CT as well as perfusion scan, there was no significant difference in baseline clot amount at diagnosis or 12 months later in either the group that had impaired functional capacity on testing or not. They additionally found predictors of functional impairment post-PE, and these included male sex, age with a risk ratio of 0.98 per 1 year increase in age, elevated BMI, current or prior smoking status, and persistent impairment that was evident at 1 month post-diagnosis. Interestingly, things that did not have or were not predictors of functional impairment post-PE included known lung disease, baseline physical inactivity, unprovoked versus provoked status of their VTE, concurrent DVT, number of symptoms that they had prior to their diagnosis, overall thrombotic burden, and right heart strain were not associated with functional impairment. They further looked at patients in terms of their overall improvement of their VO2 max, and overall around 65% of patients did have an overall improvement in their peak VO2 max from 1 month to 12 months post-diagnosis. The mean improvement was quite small, around 4.5%, but was significant regardless. And among those that had an impaired VO2 max at 1 month, the majority of them continued to be impaired at 1 year. They looked further into the variables from the 12-month cardiopulmonary exercise testing and echocardiography and found that there was no evidence of hyperventilation or high dead space ventilation as seen in CTEPH. There was also no evidence of impaired gas exchange suggested by desaturation. And overall, there was a significant difference in the peak heart rate that was achieved in those that had decreased VO2 peak. And overall, this was suggestive of suboptimal effort, suggestive of deconditioning. When looking at PFT data and echocardiograph findings, there were no variables on PFT that were significantly different between the two groups. Oh, I lost a slide there, sorry. And there was no significant difference in echocardiography findings for either of the groups. Overall, authors concluded that over 50% of patients do have persistent exercise limitation at 1 year. When looking at this generally healthy cohort, and 87.5% of that on the basis of their CPET testing is suggestive of overall deconditioning. These symptoms are unrelated to residual vascular obstruction on imaging, RV to LV ratio or size of PA diameter, suggestive of increased pulmonary pressures. And the majority of this post-PE dyspnea was secondary to baseline deconditioning. The question of deconditioning has raised the question of the utility in pulmonary rehab. And this trial from 2023 was an RCT including 211 patients that had persistent dyspnea following PE that had no evidence of cardiopulmonary comorbidities. They were randomized 1-to-1 to either rehab or the control group, where the rehab consisted of 2 weekly physical exercise classes for 8 weeks, plus an educational session, while the control group received usual care. Their primary endpoint was looking at the difference in their shuttle walk test distance. And secondary outcomes were looking at overall endurance, quality of life scores, dyspnea scores, and they also did a PE specific quality of life score as well. In looking at the results from the incremental shuttle walk test at baseline and follow-up, there was a improvement in the rehab group as compared to the control group with the utilization of the rehab. However, when looking at their quality of life score, so their general quality of life score is at the top, and then shortness of breath or dyspnea score is at the bottom, there was no significant difference. But with the PE specific quality of life score, there was a significant improvement in the rehabilitation group versus the control group. Overall, post-PE dyspnea, when it comes to post-PE dyspnea, there's limited evidence that supports a circulatory or origin of their persistent exercise limitation. There is some question that it's underlying unmasking of chronic comorbidities that are sort of brought to light after their acute event. And there's conflicting evidence behind the clinical etiology, that being deconditioning or identifiable diagnoses that can be made. There has been shown to be some benefit to post-PE rehab. However, it's unclear the best method of patient selection, timing of implementation, and duration, with more studies needed to elucidate that. Conversely to post-PE syndrome, CTEPH represents the more severe manifestation of PPES, which is the result of persistent residual vascular obstruction plus post-PE functional impairment in the setting of precapillary pulmonary hypertension on right heart cath with a mean pulmonary artery pressure of 20 or greater than 20 and pulmonary vascular resistance greater than 2 Woods units. It is a progressive disease in the absence of treatment. And although a lot of studies are kind of all over the place in terms of the general incidence, the general consensus is at somewhere between 2 and 4%. Interestingly, despite what we know about the disease so far, there is about 25 to 30% of cases that are diagnosed in those that have no history of a symptomatic VTE event. In terms of the pathophysiology, several factors play a role. First, with the development of persistent pulmonary artery obstruction resulting from incomplete thrombus resolution, there's been a lot of proposed mechanisms involved in this, including abnormal fibrinogen structure and function, inflammatory thrombosis and inhibition of intrathrombus angiogenesis. There's been some suggestion that in situ thrombosis may play a role as well. Residual obstruction, residual thrombus triggers an abnormal healing response, leading to formation of a scar and overall vascular remodeling, which in turn narrows and stiffens the arteries, leading to further obstruction and pulmonary blood flow. Obstruction of pulmonary blood flow and persistent, overall persistent obstruction. Fibrothrombotic lesions are seen, and you can see them on CT. Obviously, I can't see them with my eyes, but radiologists can. They consist of webs and bands, partial recannulization, stenosis, retraction with general narrowing of the wall, and then retraction with partial inclusion. All of this leads to an increase in mean pulmonary artery pressure, which is then followed by vascular remodeling that results in small vessel arteropathy, microvascular thrombosis, and intimal proliferation. Interestingly, these microvascular remodeling is seen in both the obstructed areas as well as non-obstructed lung areas, likely due to redistribution of flow due to the increased pressure, and which increases the pressure in unaffected arteries that then results in shear stress in those non-affected vessels. Over time, this is progressive and leads to further increases in pulmonary vascular resistance, resulting in increased right atrial pressure that leads to pulmonary hypertension, hypertrophy of the right ventricle, and overall right ventricular dysfunction. Over time, this can lead to impaired left ventricular filling due to the interventricular dependence between the ventricles that can reduce coronary artery perfusion, as well as over time reduce cardiac output. When looking at the risk factors for CTEPH specifically, there's been a lot of proposed risk factors. While of course a history of acute pulmonary embolism or recurrent pulmonary embolism holds the risk, there's been a suggestion of hemostatic risk factors, including differences in coagulation cascades, potential antibody responses to different factors, as well as further increase of comorbidities playing a role as well, including cancer, thrombophilia, most specifically antiphospholipid antibody syndrome, that in itself has a CTEPH prevalence of around 3.8%, genetic susceptibility, inflammatory disease, obesity, and smoking. Additional risk factors include the delayed presentation of acute PE, severity of the index event, with some studies also showing that female sex holds a greater risk as well. Briefly speaking about CTEPH management, the general consensus is indefinite anticoagulation to prevent additional VTE recurrences. There was been a lot of question as to whether DOAC or vitamin K antagonists were the better answer. And a lot of studies kind of go back and forth. There was a recent meta-analysis in 2024 that combined all of the observational data that was available, and overall concluded on the basis of low quality data that there was no significant difference in VTE recurrence or all-cause mortality between those using warfarin or DOAC. All of these patients should be referred to, for mechanical treatment, that being endarterectomy or angioplasty. There's been no head-to-head trials delineating which is the best, but the general consensus is that for those that are more proximal disease, PEA might be more beneficial, whereas balloon angioplasty might be more beneficial for the smaller, more distal vessels. Both of these have demonstrated an increased overall increase in survival of these patients following mechanical treatment. And the use of pulmonary hypertensive specific drugs have also been shown to be beneficial, especially with those that have predominantly microvascular disease, which can be determined by a discrepant degree of obstruction to the degree of pulmonary hypertension that they have. CTEPH screening, as you all know, should be done in those that remain symptomatic after 3 months of anticoagulation. Those that have signs of CTEPH at their acute PE diagnosis, which the incidence of this is seemingly increasing. Suggestions of CTEPH at that diagnosis are significantly high right atrial pressures, which physiologically could not be achieved in the setting of acute pressure overload, because the RV would typically acutely dilate instead of hypertrophy and create that degree of excess pressure. And then other findings on CTPA, such as direct vascular signs of chronic thrombus, as previously mentioned, indirect signs of RV hypertrophy, right atrial dilation or collateralization, and then parenchymal changes as well, with mosaic attenuation around the areas of obstruction. The general recommendation is those that are at high risk, so large PE, significant RV dysfunction, or pulmonary hypertension on echo at diagnosis should also be screened, regardless of symptoms. Chronic thromboembolic disease, or CTED, is a more elusive diagnosis. It was initially coined to distinguish those that had persistent dyspnea in the setting of chronic thromboemboli without any evidence of pulmonary hypertension at rest. And in 2021, there was like a new term that was coined for this, and that was chronic thromboembolic pulmonary disease, which was later termed CEPD without PH, but for clarity purposes, I'm just going to call it CTED. Overall, the definition of this is that there's residual vascular obstruction in the setting of persistent cardiorespiratory impairment following adequate anticoagulation in the setting of a mean pulmonary arterial pressure less than 20 at rest, so no pulmonary hypertension at rest. This is in the absence of ventilatory limitation or deconditioning on CPET, as well as no evidence of left heart disease or other etiology. The true incidence of this is unknown. Some studies have suggested that it's half of the incidence of CTEPH, but given that there's no suggestion of an overly progressive disease, one might think that it should be higher than that. This study from 2023 had an incidence of CTED around 5.75%, but overall it remains quite unclear. The pathophysiology also remains quite unanswered. Presumably it's similar to CTEPH. There's been no studies to date that have really elucidated it. Several proposed mechanisms as to why these patients do not develop pulmonary hypertension, whereas CTEPH patients do, is that maybe there's an insufficient degree of occluded segments to affect resistance, pulmonary resistance at rest, versus those potentially they lack secondary vasculopathy and sort of this more small vessel findings. When looking at the radiographic differences between CTED and CTEPH, this study from 2021 was retrospective. It included a total of 85 patients, 40 of which had CTED and 45 had CTEPH. And they were looking at the overall differences in a range of investigations, including CTPA, right heart cath, cardiopulmonary exercise testing between the two. When looking at their function specifically and their right heart caths, as expected on their right heart caths, there was a higher or increased degree of elevated pulmonary pressures in the CTEPH group in comparison to CTED. There was also a better functional capacity in CTED versus CTEPH, suggesting that baseline function was not as severe, which could be expected as well. When looking at CTPA findings between the two, they did not find any difference in vascular obstruction scores between either CTED or CTEPH. However, they did see more evidence of mosaic hyperemia, suggestive of small vessel disease. They had higher hypoperfusion scores and more often evidence of increased pulmonary hypertension on CTPA, which is expected. And overall, they concluded that there was no difference in the overall vascular obstruction burden between the two entities. And CTED had less extension of perfusion deficits, less CTA evidence of small vessel disease, or small vessel remodeling and peripheral disease. And that potentially is why they lack pulmonary hypertension at rest. This more recent study, it was an abstract that was published in 2024. It included 72 patients and was a retrospective study. 24 of these patients had CTED and 48 had CTEPH. Overall, they found that there was actually a significantly higher overall clot burden in CTEPH versus CTED. And overall, there was more higher obstruction and more diffuse disease, with an average of more lobes and more vessels per case in CTEPH in comparison to CTED. And they also had more distal disease in comparison to the two. So in contrast to the study from 2021, this study, these authors concluded that CTEPH has greater vascular obstruction, increased microvascular disease, and more abnormalities with pulmonary artery compliance in comparison to CTED. The question of, is CTED an earlier stage of CTEPH, has been asked for a very long time now, and we have yet to sort it out. This study from 2019 did look at exercise, or using cardiopulmonary exercise testing together with exercise cardiac MRI with simultaneous right heart catheterization to determine several different indices for either of these. And they found that CTED was characterized by a pattern of RV dysfunction that was somewhere in between CTEPH and normal controls. So the top being cardiac index, and the green being CTED, red's control, and then blue is CTEPH. In cardiac index, heart rate, as well as RV contractile reserve and pulmonary vascular load during exercise, CTEPH seemed to fall, or sorry, CTED seemed to fall somewhere in between that of CTEPH and normal controls. And overall, these authors concluded that it lies in between these two things. So potentially intervening on CTED earlier may prevent the development of pulmonary hypertension and subsequent RV failure in that patient population. They also looked at, or these were different studies, but looking at CTED in terms of cardiopulmonary exercise testing. In comparison to CTEPH and normal controls. And what they found was that, again, CTED lies somewhere in between. These graphs demonstrate sort of different components of the cardio exercise pulmonary testing. O2 pulse is one index that is a measure of peak oxygen consumption over heart rate, which is an indirect marker of left ventricular function. End-tidal CO2 is looking at overall ventilation perfusion and dead space ventilation, indirect marker of cardiac function. And then, end-tidal CO2 is just ventilation perfusion and a marker of cardiac function. And then at the bottom here is ventilatory equivalent for CO2, which is a measure of dead space ventilation. And amongst all of those, CTED sort of sat somewhere in between. The greater dead space ventilation in CTEPH as compared to CTED has been proposed to be a predictor of pulmonary hypertension at rest in patients that have thromboembolic obstructions. And it's independent of the degree of proximal thrombotic burden. Overall, this study suggested that CTED may have a slight increase in pulmonary vascular resistance that's compensated for at rest, but then unmasked during exercise, leading to the question that, or entity of exercise-induced pulmonary hypertension in this group. There's also been very few studies that have investigated the natural history of CTED and whether it does over time progress to CTEPH. This 2023 prospective study included 133 patients, had a median follow-up of 37 months, and they were broken up into two groups, one with no pulmonary hypertension by our current definition, and the other one with mild pulmonary hypertension per our definition. There were overall, as one might expect, those with mild pulmonary hypertension did have a significantly higher pulmonary vascular resistance in comparison to CTED. But they also concluded, which was similar to the previous studies, that there was no significant difference in their overall obstructive index. Interestingly, amongst this study, they followed for up to 3 years, and there was no evidence of any progressive disease in those that had no pulmonary hypertension. They did have a pretty high mortality rate. However, there was no significant difference between the two groups, and the majority of the mortality was attributed to malignancy. The question of CTEPH management is very much extrapolated from what we do know at present in terms of CTEPH management. And there's no high quality studies for CTED specifically. We don't know if it progresses definitively to CTEPH. Therefore, the question of anticoagulation indefinitely is a hard one to answer, especially for people that have a provoked PE and potentially could discontinue anticoagulation otherwise. There is an increasing use of mechanical interventions, including endarterectomy and balloon angioplasty in this population, but it's not guideline based, and really it's based off of several low quality studies that are observational in nature. These were observational studies looking at the utility of PEA in the CTED population, and while all of them pretty well unanimously had improved hemodynamics, improved cardiopulmonary exercise testing, and improved symptoms with no seemingly poor outcomes. It was interesting that this 2017 one did have one, by definition, CTED patient that had no evidence of pulmonary hypertension on right heart cath, but then later did develop CTEPH following subsequent months, and ended up needing a lung transplant 10 years after the initial assessment. Now, back in 2017, our definition of pulmonary hypertension was mean pulmonary arterial pressure of greater than 25, which was reduced in subsequent guidelines to greater than 20. So it is possible that this patient really actually fell into the CTEPH category by current definitions and therefore progressed in terms of CTEPH and was not just CTED. But largely that comes down to semantics, and if that's the case, maybe there is a relationship between the two. And then this study was looking at the use of balloon angioplasty in CTED. Has included 3 studies, all of which were observational in nature. The largest was done by Kiko in 2024, and again demonstrated that the use of BPA in CTED patients was associated with significant improvement in right heart hemodynamics, exercise testing, symptoms. However, this study from 2024 did not document any significant decrease in all-cause mortality between those that were managed with BPA versus conservative management. So overall, postpulmonary syndrome is suggested to be a disease spectrum. Whether or not they're all intertwined remains debated. It's a heterogeneous group that's not dependent on residual vascular pulmonary obstruction for the group as a whole. Post-PE dyspnea may be secondary to general deconditioning. However, there seems to be a higher propensity for pre-existing conditions that may be unmasked and can later be diagnosed following the PE event. And when it comes to CTED, the natural history remains very unknown as to whether or not it is a disease process that's capable of progressing with elevated pulmonary pressures over time. There's limited evidence for the utility of surgery, and from what evidence we do have at present, it's beneficial for symptom management, with no obvious mortality benefit with current data. And that is what I have. There's any questions or comments?